Okay. Okay. So good evening, students. Last week, I think we shared resources on neonatal sepsis. So sepsis is one illness in neonates where there are two issues. First is it can be a cause of mortality and morbidity very rapidly. A baby who is stable today can actually become sick tomorrow, and we may also lose that baby because of sepsis. And the second issue is the idea and the thing about stewardship. To save the babies is fine, but when not to do the things which are not required, like starting antibiotics or withholding feeds, and not to when not to suspect and when to suspect. So these are certain, I think, finer points in neonatal sepsis. It's easier to teach right now through PowerPoint. We have tried to include certain case scenarios, but just understand where is the role of screen and how do we identify the babies who can be septic and what are the risk factors. So we wanted to emphasize on this today. And the second part of this talk would be prevention of sepsis. If time permits, we will cover prevention in detail. Otherwise, we'll just touch upon that. You can go through the PowerPoint and the resources which are posted. So we have eminent speaker today, Dr. Amanpreet Sethi, who has completed his formal training in neonatology from AIIMS New Delhi, and now currently associate professor at Faridkot Medical College, Punjab. And he has been involved in a lot of teaching courses and academic activities, workshops. So I welcome Dr. Aman. Welcome, Dr. Aman. You can begin.
Thanks, Dr. Pratima, for the nice introduction. Am I audible?
Yes, you are audible. The screen is also visible, full screen. Yes.
So I will start today's presentation. It is on neonatal sepsis. It is one of the most important topics because as we are working in a tertiary care setup, and this neonatal sepsis is the most dreaded thing which we are afraid of. I think we put in a lot of hard work, and then we lose babies to neonatal sepsis. So this is very bad thing which happens. And the only three, I think, simple interventions can prevent this neonatal sepsis. So one is, I think, promotion of breastfeeding, and compliance to hand hygiene is very important. And again, unnecessary interventions to be avoided. So these three most important things can prevent neonatal sepsis. But I think we will go into the details. So I will start my presentation today. So neonatal sepsis is the second most common cause of neonatal mortality in India, and I think it is in the world also. So we lose almost 1 million babies to neonatal sepsis. So it is one of the most important topic. So I urge all the students to please listen carefully. So we have case scenarios in the end also, so that you are better aware of the topic. So our learning objectives will be identify neonate with sepsis. So this requires a great deal of experience. Then we need to enumerate the important etiological organisms, and then the issues of sepsis screen, when not to use and when to follow sepsis screen, and then how to treat neonatal sepsis. And the prevention and case scenario part will be done by Dr. Pratima in the end. So by definition, neonatal sepsis is a clinical syndrome, and it is characterized by signs and symptoms of infection, but with or without accompanying bacteremia in the first month of life. So it includes various systemic infections like septicemia, meningitis, pneumonia, arthritis, osteomyelitis, UTI. But I think simple skin boils doesn't is not called as neonatal sepsis. So there are systemic signs. There should be some systemic signs of infection. Then we generally classify neonatal sepsis into early and late. So we all know that early neonatal sepsis occurs between birth to 72 hours. But different classifications are there. Some take 7 days, but in India we use usually 72 hours. And the most common source of organism is maternal genital tract, but it can be the delivery room area also. So most commonly it is from the maternal genital tract, but delivery room area can also cause early onset sepsis. So the usual clinical presentation in early onset sepsis is multisystemic, and it is very fulminant. So early onset sepsis is very quick, and you have to be very fast because you will lose the baby in a matter of hours, I can say. So mode of transmission is usually vertical in utero, or usually in the delivery room, as I told you, intrapartum. The late onset sepsis is usually after 72 hours, and there are some risk factors like complication of like preterm babies are more prone for late onset sepsis, and it is usually the source of organism is usually postnatal environment, or our hands, and hospital environment is the most common source of organism. And the usual clinical manifestation is focal, and meningitis is very frequent in this late onset sepsis, and mode of transmission is usually horizontal. So the risk factors for early onset sepsis are preterm baby, low birth weight baby. So clinical choriamnitis with prolonged leaking PB for more than equal to 18 hours, prolonged labor, foul smelling liquor, or single unclean or more than equal to 3 sterile examinations. So these are uh, early onset neonatal sepsis risk factors. Late onset risk factors are usually caregiver oriented. So NICU care, so frequent invasive procedures, poor skin integrity, as I um, usually suggest in rounds also. So don't do more skin pricks, frequent handling, repeated courses of unnecessary antibiotics, and again overcrowding and NICU understaffing, and less hand hygiene compliance. Then poor nutrition is also important. So delayed initiation of internal feeds, more usage of IV fluids, and lack of mother's own milk. So these are the risk factors for late onset sepsis, and late start of KMC also. So these are the risk factors for late onset sepsis. So clinical features are usually so the baby will be lethargic. So general symptoms will be the baby will be lethargic, the activity will be poor, and there will be poor cry, poor weight gain, and there will be sometimes abdominal distension. So vomiting, there can be greenish and yellowish aspirates, poor perfusion, and shock. So these are late manifestation. So you need to catch the baby early. So if you are finding the baby in shock, or in already baby is in DIC, then you are late. So always try to be vigilant in examining the baby, and try to catch the babies early. So symptoms of pneumonia are usually cyanosis, increased FIT requirement if the baby is on respiratory support. There will be increased tachypnea, worsening Downey score, Silverman score, grunting, apnea, and increased incidence of apnea can be a marker of sepsis. And meningitis, so there will be fever, seizures, high-pitched cry, excessive crying, neck retraction, so bulging fontanelle, and then diarrhea. So diarrhea is common if you give formula feeds, and sometimes it can happen in EBM if you are not washing hands regularly. Then scleroderma is a dangerous complication, and it is uh, basically recognized as diffuse hardening of the subcutaneous tissue, and it is a late finding, and the babies are very sick if you are finding scleroderma in the babies. And renal failure, so renal failure can be because of sepsis, or can be because of the drugs which we use. So these are also poor prognostic signs if you are finding renal failure and scleroderma in a baby with sepsis. So how to diagnose sepsis? So there are direct methods, and the most common gold standard which is used is isolation from blood. CSF, urine, or pus. So we usually do blood culture and always try to send the blood culture prior to starting antibiotics. Even if you are not getting enough blood, so I will prefer to send blood culture as compared to the sepsis screen. So if you are not getting enough blood in the baby, prefer sending blood culture at least 1 ml to the lab. And the issue with the blood culture is that you need at least 1 ml of blood so that it is properly the ratio is maintained from with the broth. So 1 ml blood culture is important, and always try to keep the blood culture bottle after collecting the sample at room temperature or in an incubator at 37 degrees Celsius. So don't put the blood culture bottle after collecting the sample in the fridge. So this will hamper the growth of the bacteria, and this will lead to the poor yield of the blood culture. This is very important, and always try to collect the blood culture in aseptic technique. So don't do it without wearing gloves and without proper hand hygiene and proper cleaning of the site. So this will give spurious results, and this will be harmful for the baby. Then indirect methods. So we all are very fond of sepsis screen. So sepsis screen contains 5 main parameters: leukopenia, neutropenia, immature neutrophil to total neutrophil ratio, micro ESR, CRP. So these are the 5 parameters which are commonly used. So in TLC is usually in neonatal sepsis is low. So you will find leukopenia as the most important manifestation, and neutropenia is also common, so less than 1800 as compared to the neutrophilia. So if you are finding neutropenia and leukopenia, then there are high chances of sepsis in this baby. And immature neutrophils are also found, which comprises of band cells, metamelocytes, and myelocytes. So these are immature cells secreted from the bone marrow in response to the infection episode. So bone marrow pushes the immature cells into the circulation. So you will get a higher proportion of immature neutrophils in the circulation. So micro ESR, there will be a fall of more than 15 millimeter, but you need special centrifuge tubes, microcentrifuge tubes for getting that. And CRP, our most favorite marker. So we keep a cutoff of more than 10 milligram per liter. And so if it is more than 10, then it is taken as positive. So, so we all know that, so these are the findings, common findings. So if two or more are positive, then we label it as sepsis screen positive. But the issue with the sepsis screen is that, so it has a good negative predictive value. So means negative sepsis screen helps us to rule out sepsis. So so if you are suspecting sepsis and you are in a two mind that whether you should start antibiotics or not, so in that case sepsis screen might be helpful. If it is coming out negative, then you are relatively sure that baby is not septic. But a positive sepsis screen uh, is positive sepsis screen may not be confirmatory. So it can be positive sepsis screen can occur in other conditions also, like PIH, perinatal asphyxia. So any baby with meconium aspiration syndrome. So neonate with positive sepsis screen may have an infection, or it could be positive due to other reasons. So so if you are, so my take is that if you are relatively sure that clinically the baby is looking septic, then no need to do sepsis screen. So only send blood culture and start antibiotics. So if you are relatively sure that this baby is having all the symptoms of sepsis, so there is no need to send sepsis screen. And there are also no routine usage of serial CRPs, which are commonly used in neonatal ICUs to monitor infection, because it will unnecessarily increase the prick rate in the baby. So lumbar puncture is important. So we usually advise lumbar puncture in all cases of clinical sepsis. So in late onset sepsis, it has to be done. and even in early onset sepsis. So if the clinical picture is consistent with the septicemia or meningitis, or in the presence of a positive blood culture, lumbar puncture has to be done. So around 25 to 30% of septicemic neonates may have meningitis. So lumbar puncture is very important and it is usually missed. So if you are missing lumbar puncture meningitis in these babies, then the baby can later land up with post-meningitic hydrocephalus with untreated meningitis. So it is very important that you do lumbar puncture in all babies with sepsis. Uh, it may not be done in babies if you have started antibiotics solely because of the risk factors. Then management. So maintain temperature, airway, breathing, and circulation. Ensure optimum oxygenation. So maintain saturation between 91 to 95%. Maintain normoglycemia. Give injection vitamin K 1 mg earlier not given. Then avoid enteral feed if hemodynamically baby is not stable. But if you feel that baby is now hemodynamically stable, then enteral feeds can be started. And if there is scleroderma, then you can consider exchange transfusion because it has shown some benefit in improving the survival of the baby. So antibiotic policy is very important. So broad spectrum antibiotics to be used. Empirical upgradation can be considered if there is no clinical improvement by 48 hours of institution of antibiotics or the condition deteriorates. So how can you say that condition deteriorates? So there are some signs like when the baby was improving earlier, then suddenly the baby went into shock. There is increase in inotropes and the shock is now unresponsive. So there is increased in effort requirement. There is increase in the secretions. The texture of the secretions have changed and the baby went into or baby is going into DIC. So these are the situation. If the baby is deteriorating rapidly, then you can consider upgradation earlier also. So no role of serial measurement of CRP. Then calling conditions, antibiotic policy is very important. So don't give prophylactic antibiotics and don't give any all the babies with meconium stained liquor with meconium aspiration syndrome antibiotics. So not all babies with respiratory distress are having sepsis or congenital pneumonia. So perinatal asphyxia babies doesn't require any antibiotics. And if there are only 1 to 2 risk factors for early onset sepsis, then you can briefly monitor the baby, but don't start antibiotics. Or prematurity or jaundice or any baby with cyanotic heart disease. So these are common conditions in an ICU. So don't start antibiotics in these babies because it will increase the resistance rate. Then when to stop antibiotics? So culture negative sepsis. So if the blood culture is reported sterile at 48 hours, the following guidelines can be used. So asymptomatic baby at risk for early onset sepsis with positive sepsis screen. So not performed initiated on antibiotics. So if you have started solely on the basis of positive sepsis screen and the baby is now asymptomatic, then you can immediately stop the antibiotics in these babies. Then asymptomatic babies. So in symptomatic neonate, you can continue antibiotics for more than 5 to 7 days, but stop at 7 days if the culture is negative. But if the culture is positive, then stop antibiotics after 10 to 14 days. And if you find meningitis in lumbar puncture, then stop antibiotics after 21 days. So next important topic is antibiotic stewardship. So this is a good upcoming topic. So you can get a question in your exam also on antibiotic stewardship. So the main principles of antibiotic stewardship is you if you are starting antibiotic in a baby, then it should be timely and there should be appropriate antibiotic utilization. So you should be thus the regimen selection should be appropriate. So don't combine like meropenem with metronidazole. So these are the antibiotics which are for anaerobic. So meropenem covers both anaerobic and gram negative bacteria. So don't combine meropenem with metronidazole. So it should be appropriate selection of a regimen. Optimization of the dose is important. Route and duration of therapy should be protocolized. So don't. So I always ask my students to check the doses, the duration, and how to give the antibiotics. So before giving so it is always better to keep a book at your side and check the dose before giving. And these principles should be applied to empirical use as well as definitive use. So this is my part. If you have any questions, you can ask. One thing I want to cover again is that so if you are doing a CSF in a baby, so there has been a latest change in the FBNC guidelines. So they have maintained the cutoff of CSF cells more than 25 per microliter with polys more than 60%. So they have given the criteria to how to diagnose meningitis on CSF, and CSF glucose is less than 20, or CSF blood to glucose ratio is less than equal to 0.6, and CSF protein is more than 150 in term babies or more than 180 in preterm babies. So if a baby is having either CSF cells of more than 25 per microliter with polys more than 60%, will be diagnosed as meningitis. Or if you are not getting any cells, but you are getting hypoglycorrhea along with high protein in the CSF, then it will be classified as meningitis. And basics for doing CSF is that as soon as the sample is taken, try to do the cytology and the metabolic profile within 30 minutes so that the spurious results are avoided. So this is all from my side, and case scenarios will be taken by Dr. Pratima. If you have any questions, you can ask.
Please type your questions in the chat box regarding meningitis diagnosis, which Dr. Raman told. I think is there in the FBNC module also. It's very important. And any other doubts regarding sepsis screen, you can please ask, because then it has to be interactive. The case scenarios we will be asking you, you type in the chat box, okay? You can stop sharing. You can stop sharing, Dr. Raman. I will share.
I will not be telling you about the antibiotic regimens because each unit has its own protocol of giving antibiotics. So you have to follow your local antibiograms before selecting antibiotic regimens in your unit. So if you are getting more of gram-negative sepsis, then the antibiotic regimen will be different for your scenario. But the usual recommendation by the facility-based newborn care is that you start with MP and Genta. But in our unit, we start with the piperacillin, tazobactam, and amikacin. So every unit has its own antibiotic policy.
Yeah, for postgraduate, it is important that you should know your unit policy. I'm sure every unit, tertiary unit will have a written antibiotic policy, first line, second line, third line, and reserve antibiotics. So first line usually cover 80% or more of the organisms which are grown. And normally what we do is in NICU, we look at the surveillance reports of last 1 year and culture reports, and then make a policy ki 80%, 85% organisms should be sensitive to those. So as Dr. Raman said, some units may be still using AMP, Genta, some may have upgraded to peptide as first line. Thank you, Dr. Raman. I think they are not asking any questions, so we will start asking them now. Yes, Dr. Ashok Garg has commented that any intervention which the baby is having, always on rounds, you should discuss and decide whether he needs the IV cannula, whether he needs the line, whether he needs the antibiotics, whether he needs the respiratory support, whether he needs oxygen, whether he needs so much of FiO2. So on the rounds, it is very important to audit daily whether whatever intervention the baby is getting or treatment the baby is getting, whether it is required daily or not. I'm still not able to share the screen. Momita, Dr. Aman has stopped sharing, I think. Dr. Aman, you can stop
I have
sharing the
stopped
screen.
sharing.
Yes, ma'am.
It's still visible. Your screen is still visible, I think. Can you stop sharing the screen, Momita? Can you do
Yes,
that
ma'am.
from
Yes,
your
ma'am.
end?
Yes, ma'am. I can do it. Just a moment, ma'am.
Okay. So participants, I request you to be active and just type the answers. We are not going to deem it correct or incorrect. We just want to know how you are actually making a decision in cases. And these are just template examples. And bedside, you need to discuss each case on its own merit. And clinical monitoring by as far as possible objectively, like using the distress scoring, using the FiO2 requirement, using the monitoring sheet to look at the other parameters like presence of shock or not, will help you decide whether the baby's status quo, or he's deteriorating or he's improving. So based on this situation, daily you have to audit whether he needs any other further intervention in form of investigations or any antibiotics. So in NICU, each baby is sick, and sepsis is a great mimic. It can mimic any condition, including distress, hypoglycemia, hypothermia, any condition which is coexisting can mimic as sepsis. So it is very important to actually have a look at the baby as a whole. So let us see the first case. So he's a 38-weeker baby, birth weight of 2,850 grams, vaginally delivered and at certain date and time, born to a primary mother in a booked pregnancy. The baby was born through meconium strain liquor, and there were no other risk factors for sepsis, which was discussed in the first part. And at birth, he cried immediately after birth, and the APGAR score was 7-8 at 1 and 5 minutes of life. He was admitted to NICU with distress, and other vitals were maintained. And at 30% FiO2, the saturation was 94%. So the question is, what should we do next? Is a sepsis screen required in this case? You can type in the chat box the answer to these questions, 3 questions. Should the baby be started on antibiotics, and should the neonate be started on feeds? So please type in your chat box, everybody. Should a screen be sent? Should antibiotics be started? And should the neonate be started on feeds? Okay, Priya has written no antibiotics. Very good. Any comment on the screen? Feeds is yes, yes, Vipul, no antibiotics. So why not antibiotics? The baby seems to be sick. He's having distress with 30% FiO2. Okay. Right. So very nice to see the interaction. Very good. So let us understand. Okay. There are 4 case scenarios. So observe carefully what we are trying to say. Okay. So now this baby, if you look at this, the first slide, you observe that there are risk factors. This is to be highlighted. There are no risk factors for sepsis. He's a term baby. And the distress is there, but there is cause for distress, which is meconium strain liquor. So you'd see the baby as a whole. He doesn't have any risk factors for early onset sepsis. So what was the criteria, which was a broad criteria, which was told that presence of 2 or more risk factors in an asymptomatic baby. Now here, why would you take this baby as asymptomatic in terms of sepsis? Because he has an alternative reason for distress, which seems to be stabilized on CPAP. and there is no shock, and the other parameters are well maintained. So there was no risk factors for sepsis, and baby settled on respiratory support. So screen is also not required in this case. You just have to monitor the baby clinically. Now the monitoring by postgraduates is very, very important. In our unit also, the SRs are there, fellows are there, but still the postgraduates are taught about the basic distress monitoring, temperature monitoring, SpO2 monitoring, and the monitoring of the shock. So you have to monitor the baby for worsening clinical situation. And of course, as you all said, antibiotics are not required at all. Not even investigations are required. So that is one modification which you should note. For early onset, any symptom, you just first look at the presence of risk factors or not. If there are no risk factors and there is a cause which can explain the distress and the distress is stabilized on a certain respiratory support, you need not work up. You wait and watch. And as you all said, that feeds can be started. So this was case 1. Just note there are no risk factors and distress was stabilized. So obviously he by day 3, day 4, as he was meconium stained, baby born from meconium stained liquor, he stabilized on day 4, day 5. And we started on full feeds, and he was a term baby. So by the time he was off respiratory support, breastfeeds also could be initiated and was discharged early by day 7 or day 8. If you compare it versus an aggressive management or unnecessary interventions in terms of IV cannula, IV fluids, antibiotics, what would have happened? First of all, there is predisposition to hospital-acquired infections because of interventions. Secondly, the prolonged hospital stay. He may not get sepsis otherwise, but he will be staying long. Why? Because he may have been started on IV fluids, gradually shifted to oral fluids, and then breastfeeding. So here we see the baby was well prepared. He was started on feeds right from day 1. And as soon as he was off CPAP, he was initiated on breastfeeding rather than transitioning gradually from spoon to breast. So you have to assess the baby case to case bedside and be aggressive in feeding, and be cognizant and be a little frugal on starting antibiotics. Now,
I
coming
think
to case 2.
we can emphasize, Dr. Fatima. I think most of them are writing that sepsis screen should be sent. So we should emphasize that sepsis screen is not required in this case. I think other things they have written correctly. So sepsis
Yeah,
screen is
other
not
things they have
required in each
written
and every
correctly.
bit.
Yes, yes. So screen, dekho, we need not send in everybody. Whoever is saying that we should send the screen, have confidence in your unit protocols, in asepsis protocols. And if there is an alternative diagnosis, like perinatal asphyxia hai, uski wajah se lethargic hai, meconium strain liquor hai, us wajah se distress hai, which is stabilized. So bedside monitoring, which we keep on saying, is very, very important. Don't take it ki bhai kya wohi respiratory rate, wohi SpO2, wohi monitoring likh rahe hain. But that monitoring itself will decide whether to intervene or not, right? So this baby must have been on the same support, same distress on the next 48 hours or so. And as soon as we saw that distress was settling, the RDS score was reducing, we have stopped the respiratory support. And by day 4, day 5, he was off respiratory support. So I think well done everybody that you didn't start antibiotics. So that was a good decision. Okay. Now coming to case 2. This is a baby 2, 32 weeks, preterm baby, 1,480 grams birth weight, delivered vaginally to a second gravida mother. She was unbooked. She received incomplete steroid cover with 2 doses of dexamethasone. And there were risk factors for sepsis which were present: leaking per vaginum for 48 hours, total leukocyte count of the mother, which was more than 12,000 in some cases and 14 dimensions. So it's 18,800, 90% of polymorphs. But when the baby was born, baby cried immediately after birth with an APGAR score of 6 and 8 and 1 and 5 minutes, admitted with respiratory distress with a Silverman score of 4/10. Now here we emphasize that scoring and objective scoring is important. Why? Because delivery room में कितना था, NICU के आने के बाद कितना रहा, over next 24 hours कैसा रहा, that is very important to note. So he was maintained with temperature. Now here the emphasis is, if you do not maintain the temperature well in this baby, if you do not maintain the sugar well by screening and by starting feeds, he may develop grunt. He may develop certain symptoms which may mimic sepsis. Now the unit will think that he has developed sepsis. So that is why don't forget the basic management of temperature, airway, breathing, and respiratory support, appropriate respiratory support. So regarding airway and breathing, since he was a preterm baby, 32 weeker, he was started on non-invasive support of CPAP, and monitoring was done with SpO2, heart rate, capillary refill time, and pulses were well palpable. So this was the situation. So now, remember, what should we do next? Should the sepsis screen be performed here or not? So what was the scenario? I will take you to the first again. So this was the basic scenario, and the condition was that on 6 by 30%, saturation was 93%, and he was hemodynamically stable. So in this slide, what would the team do now? Can you type in the chat box again the same question, whether the screen should be sent? Okay. Yes, sir, Ashok sir, we agree that sepsis screen is the most misused investigation. उसको हम सोचते हैं कि confidence देगा हमको या let's do something and then बोलेंगे कि screen भेज दिया है, we will wait. But pre-test probability बहुत जरूरी है. आप test भेज क्यों रहे हैं? ये that's very important to know why you are sending the screen at the first point. So have enough suspicion, so you send the screen. Yes, people are now students are saying yes. We will send the screen. So let us see why we should send a screen, and should the antibiotics be started? So let us see why the screen should be sent. We'll come to the next question later. So now here also just note that you can follow whatever protocol, but stick to one protocol. Regarding risk factors for sepsis also, there are 2 or 3 protocols which are circulating in NICU. One is by AIMS, the other may be from NNF, or the third may be from CTC or NICE guidelines. So whatever group of risk factors you take, just stick to that. The unit should be sticking to that. So we have this our protocol in LHMC, our own protocol. So for that, we have defined certain risk factors which we take as significant. So of these, there are 2 risk factors which were present. The baby was very low birth weight preterm, and there was prolonged rupture of membranes also. So that is why a screen was sent. Now look at the screen. What do you interpret of the screen? Is it positive or negative? What was told in the first part of the talk? When is the screen called positive? When there are more than 2 positive parameters. So is this screen positive or negative? Screen should be sent. That is the right answer. Whoever was told. Very good. Multiple risk factors is also told. Is this screen positive or negative? Fatafat say. Some people should answer in the chat box. Yes, Priya says negative. Anybody else? Okay. Wonderful. So everybody knows now that the screen is negative. So here it has helped. Here it has helped the team to there are 2 approaches. Dr. Raman said that if you are reasonably sure, if the unit has 1:1 human resource, you have a very intense monitoring, then you can actually omit this also and straight away start antibiotics after culture if the baby deteriorates. But then what does this do? This gives us time that, okay, if the screen is negative, we are negative predictive value is more. We are a little assured that it's not sepsis. So should the baby be started on antibiotics, and should the baby be started on feeds? So any answer to these 2 questions?
In this, I think
So yeah,
this
Vipul,
baby
no.
actually behaved like the syndrome. Like if you are treating RDS and the baby is behaving like RDS, then no need for antibiotics. But if the baby is now this baby gets into shock, so then it is not behaving like RDS. So in that case, then I think antibiotics should be started. And so you need to follow the baby very intensely. Huh? So if there is any discourse in the management of the baby, then better to be safe than sorry, I think. Hmm.
Yes. So Vipul is asking whether we should start antibiotics. No, Vipul. even though you see that is what this one step of sepsis screen will help us to withhold ourselves. Even though there were two risk factors, he was a preterm baby, but we considered it as a risk factor, the prematurity, and we did send a screen. The screen was negative, two screens negative, so we were a little assured. And the baby also behaved like RDS. He was stabilized, and there was no shock, there was no hemodynamical instability. So antibiotics were not started. So this screen gave us a little bridge between deciding on antibiotics versus no antibiotics. We didn't start antibiotics, and there is nothing called empirical antibiotics. The units which are moving away from screen, they also don't start empirical antibiotics. They actually start antibiotics on strong clinical suspicion with cultures. So we are relying on sepsis screen, and sepsis screen in this particular case, and in such cases in the unit, they do help us. If it is a preterm baby with distress, with risk factors, you don't know, you are in dilemma what to do. The distress is status quo. If the distress is settling, he's on 21% FiO2, the FiO2 requirement has reduced, then of course you are very confident that it is not sepsis, is not deteriorating. It must be RDS which has been stabilized on CPAP. So the baby also improved, as we saw that skin was negative. It did not start on any antibiotics. Monitored on CPAP, weaned from CPAP on day 9, and he was stopped CPAP on day 10. We did start feeds, and in our unit we start with full enteral feeds. Whatever your feeding policy is, adhere to that. If the unit is comfortable starting feeds with 30 at extreme preterm, do that. But at least start feeds. We start with full orogastric feeds, and you see the baby was started on orogastric feeds. It was increased as per protocol to 150, 120, 140 to 150 by day 5, day 6. So KMC was also initiated, as Dr. Raman said, that early KMC is also one of the preventive aspects of sepsis. Enteral feeds, mother's own milk, which is very important. So always look as a whole, the baby as a whole and the management as a whole. Antibiotics, कोई रामबाण या एक कोई strategy नहीं होता है which will prevent sepsis. It's the overall management which you do for the baby, which will prevent sepsis and which will save the sepsis from hospital-acquired infection. So the learning would be that always be cognizant and note the risk factors. Two risk factors, do send a screen, but withhold yourself from antibiotics. Look at the screen report, okay? Not all preterm babies with respiratory distress require antibiotics. So quickly moving to the third case. Again, a preterm baby, less than 1500 grams, VLBW baby, primary mother, unbooked pregnancy, incomplete steroid cover, and cesarean section had to be done because of antepartum hemorrhage. So looking at the risk factors, the mother did have fever, which was more than 38 degrees Celsius. Counts were raised with the polymorphs increased. And there is a definite foul smelling liquor which is there. You see the baby is also sick. The baby did not cry after birth. He received some intervention in the form of initial steps, APGAR scores for 5 and 8. And because of distress, again, he was admitted to NICU. All the other parameters were maintained, temperature, airway, breathing, CPAP was there, 6 by 40%, and he must have received surfactant. Heart rate, tachycardia was there, 176 beats per minute, capillary refill time was more than 3 seconds, and pulses were feeble, for which he would require the first step of shock management, which was normal saline bolus of 10 ml per kg. So you look at this baby, okay? Compared to that preterm baby, which was case 2, this is case 3, which is different from case 2. I hope you have observed. The clinical scenario was also different. The maternal risk factors were also different. So should the sepsis screen be performed here and should the antibiotics be started? Can you type in the chat box, the team? I'm sure you must have noted the difference in the cases. We just want you to note and observe. I'm not saying that clinically you will be facing such clear-cut babies. There will be some doubts, of course, but take the message with you. Yes. So I'm sure everybody realizes that this is a sick baby born to a mother with risk factors. He developed shock. Foul smelling liquor was there. So there is definite risk factors. So there were 3 risk factors which were present as per our unit protocol. You can adapt any protocol which the unit faculty agrees with, the unit in charge. And clinically also the baby was sick. Screen was sent. Even though he may qualify for antibiotics, but screen we do send. There was screen was positive. Culture should be sent before starting antibiotics. And for how long does the baby need antibiotics now? And of course, lumbar puncture, because he's clinically symptomatic baby. So lumbar puncture also needs to be done. For this baby, we need to look at the culture report. And if the cultures are positive, then we need to give for 10 to 14 days, as was told in the first part. And screen is positive, so at least for 5 to 7 days based on the clinical situation. What do we do about the feeding? As soon as the shock is resolved, the baby was started on feeds, maybe not on full feeds, but on half feeds or at minimal enteral nutrition, and full feeds were reached by day 6. So you see the difference. Do not get discouraged by the sickness. Even if the baby is sick and the shock is resolved, the distress is settling. So even on day 1, you can start with MEN. Don't think that nilper orally would be helpful. Some amount of enteral feeds is protective. Even dose-dependent effect is there. So do consider feeds in such babies. So he was monitored, weaned off from CPAP and room air on day 9 and started on minimal enteral nutrition, increased and reached full feeds on day 7 to day 8. Here KMC was initiated on day 3. You can initiate on day 2 if the baby is off shock, clinically stable. Enteral feeds, mother's own milk is very important, and complete mom was given on day 4. He was discharged. So learning from this case is that early signs of sepsis, don't forget early detection of shock, and supportive management is very important. So last case, this is a different case. Those 3 were early onset sepsis. They were manifesting right on day 1 and birth. This is the baby who is presented on day 5, and as per definition, he is a late onset sepsis case. And he had distress with a Downey score of 4/10 and also symptomatic with fever. So clinically speaking, we gave supportive management first, temperature, airway, breathing, and he did have hypothermia. He was brought from home, started on CPAP, stabilized on 5/30%. There was no shock. All pulses were well palpable. So should the antibiotic be started straight away, or should we send a sepsis screen? What should we do next? Can somebody type? So in our unit, even if the suspicion is strong, we are sending sepsis screen, which helps us decide. Actually, in this particular case, it was pretty clinically strong suspicion was there. So culture was also taken straight away. The reports were also positive. So first line antibiotics were started as a case of late onset sepsis, and lumbar puncture was also planned. And this was the screen, which was positive. And blood culture was also positive. So we will give antibiotics for 10 to 14 days. Feeding was continued. We continued with the feeds because there was no shock, no. So day 1 pe he feeding was there, and we completed the antibiotics for 14 days. And 15th day, the baby was discharged. So the second part of the talk is actually prevention. And I would say, and Dr. Aman would agree, and whoever has worked in NICU for more than 3-4 years, they would see that managing sepsis is much more cost intensive, effort intensive, manpower intensive, plus outcomes also may not be very favorable. So prevention is the key. And we have seen that by good asepsis routines and simple things like hand hygiene, maintaining the NICU asepsis routines are helpful in reducing the baseline or the culture positive or clinical sepsis in the NICU overall, whether it is early onset or late onset. Now the distinction between early onset and late onset is very much blurred in our setup, in Indian setups, because even labor room asepsis routines, if they are breached, the sepsis can manifest within the first 24 to 48 hours. So remember that asepsis right from delivery room to NICU. It is very rewarding, and we have ourselves seen that the sepsis rates will drastically come down if you adhere to the protocols. And these are some of the steps for prevention of infection. Another thing would be initiating the early enteral feeds, any amount of mother's own milk, minimizing the interventions like IV fluids, lines, central lines, IV cannulations, respiratory support, which are not needed. Daily audit about those things. The earlier you remove or avoid IV cannulation, that will help. Don't do unnecessary sampling, daily CRP, daily investigations. The more you prick, the more the chances that the skin breaches will be there. And there is a chance that human error of breach of sepsis will be there, no matter how minor the intervention is. So hand washing, asepsis routines, basic water supply, including ventilation and all, adequate temperature, not much of humidity. Avoid unnecessary admissions inside NICU, like only for jaundice, only for phototherapy, only for observation of distress which does not require any oxygen. So those babies should not be brought inside, and doubling, tripling should be avoided as far as possible. And if any procedure is required at all, maintain strict asepsis, which the videos have been shared with you. So these are key behavioral changes like equipment management, healthcare waste management. I'm sure you all must be knowing the 6 steps of hand hygiene, but adherence to hand hygiene is important. Knowing is okay, but adherence is as less as 40% in many good units also. The moments of hand hygiene, the poster should be readily accessible to everybody. There are 2 before and 3 after moments. So before moments are actually to prevent giving infection to the baby or the patient. Afters are basically to prevent infection and cross infection to the healthcare providers. So, and fomite-borne infection. So once you touch a folder, a baby folder or a knob of the ventilator, even those are actually predisposed to spreading infection. So after movements are very, very important, and those are the most commonly missed steps after movements. So after touching a baby, after touching patient surroundings, which includes touching the ventilator knobs or CPAP knob for adjusting FiO2. Don't think that यार मैंने तो knob ही touch किया था. Infusion pump का बस rate ही up down किया था. Many sisters or many PGs think that यार मैंने तो baby के पास भी नहीं गया. I just touched the infusion pump. I just touched the FiO2 knob or the CPAP handle. So those things actually are fomites. If you touch those and don't wash your hands, you will touch the file again or the table again and in turn spread the infection to other babies and to yourself also. So before touching a patient, before any septic procedure, after touching a patient, after touching surroundings, these two are very, very, very important because before procedure and after any exposure, हम अपने आप ही हाथ धो लेते हैं. अगर आपको urine stain हुआ, blood stain हुआ, so automatically you will wash your hands. But these moments, which are actually subtle, like after touching a patient, after touching a clean patient surrounding, apparently clean, you should be washing your hands. Okay. So this is the aseptic chain right from birth till discharge. And a lot of procedures are there which have scope of introducing infection. Just make sure that you do not spread any infection while doing any minor procedure like orogastric insertion, IV cannula, IV fluid preparation, IV medications preparation, which was discussed and videos were shared, making parenteral nutrition, invasive procedures like surfactant, suctioning. So these are the procedures and these are certain checklist. We will share the PPT with you. Another thing I wanted to share with you was aseptic no touch technique. That means the key part, which was I think stressed on the workshop also, that aseptic non-touch technique means that the key part or the critical part of the equipment should be actually not touched in an aseptic manner. So the ones which come in contact with the baby, like tip of the IV cannula, tip of the orogastric tube, tip of the ET, those should be kept as sterile as possible. Very, very important is, as I told you, dose dependent effect of enteral feed and mother's own milk. So that is very, very important. Do ask the mothers to express their milk. Give MOM to preterm babies and avoid formula and IV fluids as much as possible. Cohorting and isolation, unfortunate outbreaks can happen if there is a breach in asepsis routines. So in those cases, you have to take special measures of isolating and cohorting, which is again a very, very intense step for the NICU. So better is always follow routine steps, routine surveillance, and avoid and prevent sepsis. अगर किसी मदर को रिस्क फैक्टर्स हैं rarely and there are uncommon things with a baby who's symptomatic, just be observant and send judicious investigations which are required and start antibiotics as per the unit policy and follow the antibiotic stewardship. Okay. So these were the things which we wanted to stress today. Thank you so much for your attention and any questions we'll be happy to take.
LP before antibiotic. Ideally, so they are asking whether lumbar puncture should be done before antibiotics.
Yes, so ideally, yes. Antibiotics, if the baby is hemodynamic, see, there are 2 or 3 contraindications for doing lumbar puncture. First is if the baby is hemodynamically unstable, requiring inotropes. Second would be the local infection if it is there. And third is thrombocytopenia or bleeding, apparent bleeding, clinically sick. So apart from these 3 conditions, there is no other contraindication for doing LP. So it is ideal that before antibiotics, blood culture is to be taken. And of course, CSF culture bhi best is before initiating the first dose of antibiotics. If the baby is very sick, requiring 1 or 2 inotropes, the positioning is difficult. or if other contraindication is there, then only you will not do. Right, Dr. Aman? I think we do it before antibiotics only.
As soon as I think the baby is stable, you can try LP in these babies. Right?
Yes, Navjot, you are right. There are two kinds of CRP kits. See, the CRP में भी बहुत सारे discussions हैं. I'm happy that you asked this question. There is quantitative, qualitative CRP. So here 6 was mentioned because many kits in the hospital supply, they just give positive or negative CRP. अभी तो हर जगह quantitative या semi quantitative आ गया है. So in some of the kits the cutoff is 6 and in some of the kits the cutoff is 10. Ideally, yes, 10 should be taken as cutoff, as mentioned. And AIMS has taken its protocol from CDC mostly. The CDC protocols, the Center for Disease Prevention and Control. So 10 is the standard cutoff. But in research also, you have to predefine. So sepsis and feeding is one thing which the whatever unit is decides you adhere to that. Okay. So here I think it was mentioned as 6. So 1 is 10 is fine. 10 milligram per DL or 1 milligram per L. Any other question?
Anmol.
Hi, Anmol, Dr. Anmol. Okay. There was no hands-on workshop in J&K, neither any information. No, the second one will be done. Don't worry. Dr. Mubashir is on it. So we'll be announcing the dates very soon. We'll look into it. And if any station is not done and asepsis routines were not taught, we will incorporate in the... You are from Jammu or Kashmir, Dr. Anmol? Because Jammu, different workshop will be done. In Kashmir, different will be done. You can type in the chat box,
They
Dr.
are
Anmol.
very far away. I think better to do
Yeah,
sepsis.
Jammu अलग होता Jammu ना. Okay, Dr. Anmol, I'll look into it and we'll make sure that this sepsis part is covered in the next station. We are going to announce the dates. It will be either 7th July or 14th July. And if not Sunday, then Saturday perhaps, 6th July or 13th July. Yeah. Rashmi, can we start feeds if stool occult is positive with no abdominal distension, vowel sounds present? So I think in the feeding part, we discussed the criteria for feed intolerance. This is clear cut. Now, why did you do the stool occult test first of all? So there should be appropriate clinical suspicion for doing any test. So when do you suspect a feed intolerance or NEC in a baby who was on feeds and visibly the abdomen is distended? Then you look at the abdominal girth from the baseline. If it is more than 2 centimeter increase, you look at the pre-feed aspirates. So there are 2 or 3 criteria. First is visible abdominal distension, more than 2 centimeter. After that, you do the pre-feed aspirate. If pre-feed aspirate is more than 50%, you withhold one feed and look at it again, the distension and the aspirates. If they are settled, you give the feed. If they're not settled, then you again look at the abdominal distension and aspirates, and then you work upon that baby as feed intolerance, okay? And then you do all these workups. So don't jump into workup straight away. Or else, when do you suspect feed intolerance? If there are clear cut in the orogastric tube itself, that there is altered aspirate, then you suspect some gut abnormality or NEC. So I think this situation is a little not matching, not in sync. There is nothing in the abdomen, but you say that stool occult blood was done. So first of all, why did the team send us stool occult blood? It can be swallowed, it can be anything. So if the baby is not symptomatic in terms of those 3 parameters of feed intolerance, no need to send for any investigation. You send in this investigation only when he is qualifying as a feed intolerance baby. Feed intolerance on more than 2 occasions. Abdominal distension more than 2 centimeter, pre-feed aspirate more than 50%, or altered aspirates in the orogastric tube. Altered aspirates means green color bilious or blood stained. So if these 3 factors are there, then only you will actually further consider NEC. Otherwise, it's simple gut immaturity or feed intolerance, which will settle down if you just withhold one feed and restart the feed again in the after 4 hours in the next cycle. So you just look at the case, why the stool occult blood was sent in the first place.
So the basic point is don't do unnecessary investigation.
Yeah, you will get something or the other, which may have a lot of reasons, multifactorial, isn't it? So stick to the criteria, stick to any protocol, unit protocol, whatever it is, either NNF, JIPMER, AIMS, and look at the cross-reference from where they have taken these guidelines. You make your own unit protocols, at least for 3 or 4 major topics like sepsis, feeding. So you make protocols for these things, surfactant. So you stick to those protocols. I'm sure the unit faculty and in charges would help you in this. And adherence to these things will help you in objectifying the management rather than deciding on each case as a separate base and sending investigations and then interpreting them. So please feel free to interact in the chat box also in the WhatsApp group. We'll be, if needed, we'll be sharing the presentation. You can go through it. It's a very important topic, and any doubt you can ask in the group anytime. You all must be in the respective state groups, the North Zone groups. So do feel free. Dr. Aman, any other take-home message? I think there are no questions. So,
And I think the most things have been covered nicely. So 3 basic things to be done. Start breastfeeding as early as possible or express breast milk. Compliance to hand hygiene is very important. And don't do unnecessarily intervention. So don't do unnecessarily pricks. Don't start IV fluids. So this will reduce the sepsis rate enormously in your units. So this will decrease the mortality also. So if you are having a high load unit, so try to be as simple as possible. Start feeds as soon as possible and don't start IV fluids. Don't overcomplicate the things. Don't send unnecessarily investigation. Don't do sepsis screen routinely. Don't do CRP daily. Think these are my take-home messages.
yes, keep seeing the patients, keep observing. These 4 templates were there to tell you that late onset sepsis could be clear cut, the one who comes from home or from other hospitals already symptomatic. The early onset are the ones, and 32 to 34 weeker, where we can save a lot of interventions because these babies usually settle down if you observe very closely in the first 24 or 48 hours rather than sending screens, sending serial CRPs, which are equipment dependent. If sometimes it may be more than 10, other time it may be 8, other time it may be 12. So what will you do with those serial CRPs? It won't guide you anything. Your clinical acumen is the best judge, better than the CRP. So just be observant of the baby as a whole. Of course, don't miss the genuine cases, but don't overdo also, just like Dr. Aman said. Okay? Okay, then. Thank you, Dr. Aman. Thank you so much. Thank you, Momita, for
Thank you.
coordinating this session.
Thank you so
And I think we
Thank you
can.
so very much,
Good
ma'am.
evening, good night, everyone.
Yeah, thank you. Thank you. Good night,
Okay.
everyone.
With all due permission, I'm closing the session here for today.
Yes,
Good night.
thank you. Thank you,
Thank you,
ma'am.
ma'am.